Well, good morning, everybody. Thanks for coming at such early of an hour for us to talk about something that actually dear to my heart, dear to yours, treating patients with schizophrenia the best way we can. And really, it's quite a challenge. We have a number of different symptom domains to consider, which we'll review. I'm Leslie Citrome. I'm a clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York, and I'll be joined shortly by Dr. Christoph Correll, who's professor of psychiatry and molecular medicine at the Hofstra Northwell School of Medicine. Now, name of the School of Medicine keeps on changing. Now it's Northwell, so your email changes too every time. Anyway, very pleased to have Dr. Correll with me, a dear friend and colleague, and we're going to go over with you some aspects of the care of patients with schizophrenia. So how many here treat patients with schizophrenia? Raise your hands. Okay, those who haven't raised your hand, I'm going to have to ask you to drop your fork and leave. Actually, I'm just kidding. This is a CME presentation, so this is great. We got to put together our own slides. However, I'm not showing you pictures of my dog. That is for another time. All right, faculty disclosures. Both of us have a variety of different relationships with different manufacturers of pharmaceuticals in development and already available. And we're very interested in pharmacological interventions for the treatment of schizophrenia. This is all also in your booklets. We're going to talk about some drugs that are in development, not approved for the treatment of various symptom domains of schizophrenia, but it's important information for us to be aware of. Our learning objectives, first off, is to talk about the different domains of schizophrenia in a way that kind of makes sense clinically when we evaluate patients and then when we target treatments. We're going to talk about the different receptor pharmacology that gets involved when we select different interventions. And we're going to talk about some limitations that we currently have with our medication approaches to schizophrenia in general as well. And then we'll apply what we've learned to look at some potentially new interventions or new ways of looking at older interventions, and as well as medications that are in the pipeline that will help target these symptom domains that we've identified. Most notably negative symptoms, but we'll also talk about cognitive symptoms and depressive symptoms as well. So let's begin. The assessment of schizophrenia is often a diagnosis of exclusion. We've ruled out everything else. There's no sign or symptoms that is going to tell us definitely that the patient has schizophrenia, but there are some characteristic signs, symptoms that we've considered to be part of the disorder. There are several symptom domains that we're aware of: positive, negative, cognitive, mood. Unfortunately, there's no lab tests that we can use. There's no physical stigmata that we can identify that will help us diagnose schizophrenia with any degree of certainty. So our assessment is based on a diagnostic interview, getting collateral information, looking at old records. Now, this was actually written about 25 years ago by Will Carpenter, and it still holds true today. We can take a look at the DSM definition of schizophrenia, and it tells us that we need to identify a number of characteristic symptoms, actually 2 or greater, that have to be present for a significant amount of time during a 1-month period. There needs to be a continuous display of symptoms over the course of 6 months. There are some specific symptoms that we focus on: delusions, hallucinations, disorganized speech, disorganized behavior, and negative symptoms. You can actually be diagnosed with schizophrenia without negative symptoms, but negative symptoms are quite common. And in fact, when we take a look at the duration of the illness and trying to figure out if someone has continuous signs of disturbance, negative symptoms can play a prominent role. There has to be an impairment in functioning. That has to be a difference from how the person was before, and we have to exclude any other potential cause for these symptoms. Now, let's take a look at the continuous signs of disturbance for at least 6 months. If we read this carefully, if we successfully treat someone, it's going to be difficult to determine if this is occurring. There's actually provision in the DSM for us to diagnose schizophrenia if there is an amount of negative symptoms that have persisted. and that will count towards your 6 months. So that's kind of interesting to look at, because sometimes we're presented with patients with schizophrenia who we actually are on the ball and are treating right from the get-go, and we have to figure out, well, is this schizophreniform? Is this schizophrenia? What do we do with the, pinning a diagnosis for this particular person? So there is some flexibility in the diagnosis if we read the fine print. Nevertheless, basically a patient with schizophrenia is going to have one or more or perhaps all of these different symptoms in the different symptom domains. Positive symptoms that we are well aware of: hallucinations, delusions, disorganized speech. They may have the mood symptoms of depression, which we'll talk about in a bit more detail later, negative symptoms, which we'll talk about quite extensively, and cognitive deficits, which we'll also review rather briefly for the purposes of this presentation. They all lead to some impairment in function, and it really will depend on the individual patient which aspect is contributing more to the dysfunction or impairment in life's roles, occupational functioning, or perhaps relationship issues and so on. It differs for each person, and we know this from our own experiences, that we'll identify specific aspects of a person's life for helping them out in terms of targeted treatment. What about the course of these different domains or symptoms? When do they occur? So this was one of the questions in the pretest. And the question comes up, do positive symptoms emerge first, or do negative and cognitive symptoms emerge before that? Well, it turns out that we can actually measure impairment in cognition in people in the prodrome, before they've actually had hallucinations or delusions that are readily identified. We can also take a look at negative symptoms that also emerge before the positive symptoms. Ultimately, it's when the positive symptoms become obvious that we make the diagnosis, but when we look back, we can often identify an aspect of the person's life where they didn't function as well as they should have in school, for example, and they were more isolated from their peers. And so we can actually identify the onset of cognitive issues and negative symptoms prior to the emergence of hallucinations and delusions. They are kind of enduring, so once a person has developed cognitive and negative symptoms, they don't generally resolve so easily, whereas positive symptoms can wax and wane. We can have acute exacerbations of schizophrenia, which classically we use to describe when people have an emergence again of positive symptoms that seem to be overwhelming. But nevertheless, in the background, the cognitive dysfunction remains and negative symptoms often remain as well. Now, about negative psychopathology, there are many words that have been used to describe certain aspects of negative symptoms, and this is important because they are included in rating scales for negative symptoms. So we have avolition or apathy, lack of energy, lack of interest or seemingly lack of interest in doing things, alogia, some poverty of speech, poverty of thought, poverty of content in what people communicate, anhedonia, the inability to experience pleasure, and affective blunting and flattening. So we don't know if a person is happy or sad, they just look flat. And then asociality, impairments in social relationships. And each of these are different components in negative psychopathology. But they can be broken down into two main categories. One, an inability to express emotion, and two, the inability to, or the avolition, apathy for participating in life, in daily activities and social activities. So both the lack of interest in doing things and the lack of expression of emotion. This appears before psychosis. It reflects some changes in the brain, we think, and I'm going to show you some possible explanations as to why these occur. The longer duration of untreated psychosis is associated with more negative symptoms. So here's another reason of the urgency to treat someone when they are first identified as having schizophrenia, and not to let it go on till their early 30s, which does happen in certain parts of the world where patients don't get the treatment that they need. So here's another aspect about anhedonia, which is kind of interesting, which we don't immediately think of. And that is, patients with schizophrenia can experience pleasure, except they can't anticipate pleasure. So this may be a possible explanation as to why they wouldn't care to pursue things that are pleasurable, because they can't anticipate feeling good about it. But when presented with something that would make someone happy, they do experience that emotion. So they live in the moment. So that's one aspect of negative symptoms that goes unnoticed. And maybe we can leverage that as much as we can in terms of trying to develop some insight with our patients with schizophrenia. There's an important distinction that we need to make regarding primary versus secondary negative symptoms. We're well aware of the possibility of Parkinsonizing our patients, right? If we use high doses of antipsychotics, particularly first-generation antipsychotics, we can create essentially Parkinson's, and they won't be able to express their emotion, and they may look like they have negative symptoms, but actually it's induced, it's iatrogenic. We may sedate patients, and they may seem like they don't want to do anything, but that's because they're sedated. Or patients may be paranoid and not want to participate in social activities because they're afraid of other people or conspiracies, etc. But it's not because of negative symptoms per se, it's because of the paranoia. They may be depressed or anxious, which may prevent them from participating in life's events. These are the kinds of secondary negative symptoms that we can actually target by addressing their specific cause. Now, how common are negative symptoms? This is also in the pretest question. So if you remember, for subsequent recall, social amotivation is actually the most common negative symptom that we'll encounter in people with schizophrenia, followed by diminished expression, and then lastly, inattention or alogia. But there's a certain degree of overlap. And truth be told, many of our patients have all three of these symptoms, and we'll find them quite commonly in people with schizophrenia. So I worked for many years for the New York State Office of Mental Health. I ran an inpatient unit at a state hospital. And we had two sides to our unit. One was focused on persistent aggressive behavior in patients with schizophrenia, so they were more acute patients. The other side was not so aggressive patients. They had a lot of negative symptoms. And we had patients who really didn't want to do anything but sit on the sofa watching TV, but they really weren't watching television. It was, whatever was on was fine with them. So we saw a lot of this and saw all three of these aspects of negative symptoms: lack of engagement with other people on the unit, not really expressing any emotion, and not really, much involved with anything. So these enduring negative symptoms that we can encounter are a special kind of negative symptoms, one that we can identify in a group of people with schizophrenia and specifically target them for pharmacological interventions that are kind of different from what we've been using before. And why would we do that? Because they're not getting any better. I mean, we can treat the positive symptoms pretty easily, but what if after the positive symptoms are treated, they're no longer hallucinating or delusional to the extent that it would be intrusive? I mean, they may still have some hallucinations that are low level, that aren't terribly disturbing. They may be delusional, but it's not intruding upon their everyday activities, yet they remain with enduring negative symptoms. And they may have predominantly negative symptoms. So that's an interesting group of patients that we do encounter, and it's not uncommon. And if it's to a significant extent, they're even classified as something called the deficit syndrome, which you may see from time to time in the literature. That represents an even more extreme version of negative symptoms, but also not rare. How many here work in an institutional setting? So a number of you. Very commonly encountered in those settings because we can't discharge these patients. It's very hard to find a setting that would be suitable for them. Now, cognitive psychopathology goes hand in hand with negative symptoms. It emerges before positive symptoms, generally in the life course of someone with schizophrenia. It's been actually part of the definition of schizophrenia from day one. You remember dementia precox as a term used to designate schizophrenia in the past. It probably reflects a loss of important tissue in the brain that we all have to help us think things through and remember things and make good decisions. And there's possible accelerated loss of these particular areas in the brain during the prodrome. Both first episode and chronic schizophrenia share similar deficits in cognition, particularly in verbal memory and learning. So we can look at this through neuropsychological tests. And the degree of impairment compared to normal controls is 1.5 to 2 standard deviations below. Well, that's a lot. Right now, the best treatments we have seem to improve things by half a standard deviation. But clearly, half a standard deviation is not going to make up for 1.5 to 2 standard deviation deficits. And we can make cognition worse. We do this every day when we prescribe benztropine, cogentin. I think of benztropine as actual poison for our patients with schizophrenia. It's a strong anticholinergic. It will impair memory. So if I need to use benztropine, I need to rethink why. If a patient has EPS and I need to think about using the antidote, benztropine, well, maybe it's time that we think about using another antipsychotic with a lower propensity to cause EPS simply to avoid benztropine. There's also the issue that benztropine use will increase the risk for tardive dyskinesia. There's nothing good about benztropine. So we've used it in the past because we've had no choice. When we only had haloperidol and others of its ilk, we really had no choice. But today is a different story. So I'll get off my soapbox now and get back to functional outcomes. Functional outcomes is the ability to someone to take a bus, to go to work or go to the clinic, to prepare their food, to remember to take their medicine, and so on. It has a great deal to do with quality of life, relationships, and performance in our world. Cognitive performance is affected by two major things. That is, functional capacity is dependent on cognition and performance on negative symptoms, so functional outcomes on these two aspects of cognition and negative symptoms. Let me repeat that. Cognition enables someone to do stuff. That's the functional capacity. The willingness to do stuff or performance is based on the desire to do things, so that's negative symptoms. Together, that will provide a functional outcome that we can measure. So we need both. We need good cognition and the absence, if at all possible, of the severe negative symptoms that will impair our patient's ability or desire to do things. How do we figure all this out? How do we measure this? Well, you all heard about the positive negative syndrome scale, right? The PANS. How many here have used the PANS? So I imagine you've used it in a research setting because it takes about 45 minutes to administer these 30 items using the structured instrument that we're supposed to use, that interview. It's not terribly clinician-friendly, and certainly if you don't have 45 minutes to do the PANS, then you shouldn't be doing it. So it's not really a clinical tool, but it's a research tool, and is our gold standard for measuring symptoms. There is various subscales of the PANS, positive, negative, general psychopathology, and we can actually look at the negative subscale and figure out if there's going to be improvement in that over time. There's also different factors of the PANS. It can be divided into different factor scores, and let me go back here. 5 factors here: positive, negative, excitement, cognitive, and depression and anxiety. What do I mean by factors? Well, these 30 items can be separated out into these 5 sets of items, and these 5 sets of items are kind of independent as we observe a patient through their journey in being treated. So this is an interesting tool to assess the different domains of schizophrenia and potential targets for treatment. This gets back to the functional outcomes. It'll help figure out whether there are cognitive symptoms and negative symptoms that will drive our functional outcomes. So these 30 items of the PANSS, we measure them. Each item is scored from 1 to 7, 1 meaning absent, 7 meaning extreme. You add up everything. Someone who scores between 90 and 100 is usually in the hospital. Someone who scores about a 60 is doing reasonably well. Anyone scoring less than 60 is kind of unusual in my world. And if we do a PANSS on everyone in the audience, I think there will be many scores in around 40 or so. That's because the PANSS doesn't just measure symptoms that we would see in schizophrenia, it also measures symptoms that we see in the normal human condition. So anxiety, depression, somatic preoccupation, and so on. But 60 is kind of a threshold where you really probably will have some symptoms that only patients with schizophrenia would have. So we can take a look at those negative symptoms that are measured by the PANSS and use them. We can actually get a lot of mileage out of doing that. But it is preferred to be able to distinguish negative symptoms in all the fine gradations that those definitions earlier would define in terms of different aspects that we can target for treatment. So there have been in development a number of negative symptom scales. The Negative Symptom Assessment, or NSA, is one such scale, 16 items. It closely correlates with the PANSS Negative Symptom Factor, measures reductions in social interest and sense of purpose that are not adequately assessed in the PANSS. And this is a pretty precise measure. We'll go over a bit of that in a moment. There are competitors to the NSA 16, including the Scale for the Assessment of Negative Symptoms, an older scale and quite lengthy. There's also the Clinical Assessment Interview for Negative Symptoms and the Brief Negative Symptom Scale that have also been used. So there's a number of scales. But really the Negative Symptom Assessment, NSA 16, has been used probably more often. It measures 16 things, as the 16 implies, and these 16 items really cover everything that I mentioned earlier about the different aspects of negative symptoms. But you know, there are 4 items on the NSA 16 that are actually, you know, pretty good at figuring out the extent of negative symptoms in a particular person clinically. And this may be the wave of the future. If we do have treatments that are approved for managing negative symptoms in people with schizophrenia, we'll need some way of assessing this quickly. The NSA 4 may be the way to go. So these 4 items, reduced speech quantity, reduced range of emotion, reduced social drive, and reduced interest, can be assessed quite readily amongst our patients. And each of these items can be rated on 6 points, either not reduced, minimally reduced, mildly reduced, moderately reduced, markedly reduced, and severely reduced. Add up 1 through 6 for each of those 4 items, and you have a pretty quick assessment of someone's degree of negative symptoms. So I'm not suggesting we do this today, but if we do have an intervention that is approved for negative symptoms, I mean, we'll have to measure it somehow in a simple, straightforward way, and this may be just the ticket to do that. It takes a couple of minutes, and we have an idea to quantify the degree of severity of someone's negative symptoms. I mentioned this. How many here use the PHQ-9? So some hands go up. The PHQ-9 is a rating scale that has been adopted pretty widely for depression. And it really answers the same questions that we would ask patients anyway about their depression, except it quantifies the severity of their symptoms. And it's very helpful in terms of figuring out whether patients are getting better or worse, and whether or not we need to alter our treatment. It also is very helpful in communicating to patients and their families about the different aspects of depression. Similar here, the NSA 4 might fit that bill too in giving us, in the world of schizophrenia, a way of assessing something quickly and efficiently. Now, something that is not quick nor efficient is the MATRICS. So the MATRICS is a consensive cognitive battery consisting of 10 tests measuring cognition over 7 domains. This is not something that can be easily done in the office. You need some training to do these measures, but it is used in research in the outcomes that we assess regarding cognition. So it measures, let's say, processing speed and working memory, visual learning, etc. And this is well established, and you'll see this all the time in the research literature. It serves as an outcome measure for interventions that may help with cognition. It serves also for cognitive remediation outcomes. It also gives us a sense of if there's going to be any significant change in someone over time. And it's also very useful to get a baseline assessment of someone's cognitive ability. So it's actually quite versatile, but it's not something that I can easily use in my office, for example. Measuring functionality is a bit of a challenge. We know it when we see it to a great extent when we do our clinical interview and we ask our patients about their activities of daily living. There are a couple of scales here that you'll see in the literature. The Personal and Social Performance Scale is one that has been used in drug development and actually appears in the product labels for an agent or two out there. It describes someone's ability to engage in socially useful activities, including work and study, personal and social relationships, self-care. There's also an element in terms of aggressive, disturbing behaviors, so driven a little bit by psychopathology. And then we have something called the UPSA, the UCSD, Performance-Based Skills Assessment. And this assesses a person's ability to do things like household chores, communicate, take care of their financial issues, take care of planning issues, transportation, and so on. It correlates quite well with negative symptoms and cognitive impairment and really has nothing to do with positive or depressive symptoms. So this seems to be a pretty good way, the UPSA, of figuring out whether or not we're going to make a functional impact with our interventions that have targeted cognition, for example. So we'll see that in the literature. What can we use as clinicians in the office today? Well, DSM-5 has offered us a framework to assess the different dimensions or domains of schizophrenia. And this is called the Clinician-Rated Dimensions of Psychosis Symptom Severity tool, so to speak. This is in the main text, the textbook of DSM-5. It's not in the little handbook. It's also available online, and it's free. And basically, it allows us to assess 8 items over the course of the prior week. That's what's suggested. Hallucinations, delusions, disorganized speech in terms of positive symptoms, as well as abnormal psychomotor behavior. But importantly, it allows us to make a global judgment about negative symptoms, impaired cognition, depression, and mania, scoring between 0 to 4 for each of those items. 0 means not present, 1 means equivocal, 2 present but mild, 3 moderate, and 4 severe. So this is a tool that helps us structure our evaluation of patients, let's say with schizophrenia or other psychotic disorders, and help us figure out the domain. So available, free to use, and reproduced in very tiny print in your booklet. What about depressive symptoms and suicidal behavior? Before we get into receptor pharmacology, I just want to give you a couple of heads up regarding depression. Number one, it's pretty common, as you know, in your own experiences with patients, that first episode patients with psychosis are depressed, either during the episode or immediately after the episode. And there are various things that are associated with this, including poor adjustment premorbidly, degrees of insight which fluctuate, loss, shame, low level of continuing positive symptoms, so they are enduringly symptomatic, longer duration of untreated psychosis. We do have some information available as to who is more likely to exhibit suicidal behavior, so obviously history of prior suicide attempt, but also a history of traumatic events that have occurred in the person's life, so physical, sexual abuse, substance use, and lower baseline functioning, longer untreated psychosis, and so on. So there is a number of risk factors. Some of them are obvious and some are less obvious, and we need to really think this through in patients with schizophrenia. And I always ask about depression, even though they may not seem to express any emotion. It's always good to ask because they may not be able to express it, but they may be feeling it. In terms of the burden, it's actually quite common. In a fairly large prospective naturalistic observational study that included a couple of thousand patients, about 40% were deemed depressed. They're going to be more likely to use emergency services. They're going to be more complex in terms of their management. They may be more likely to abuse substances and so on. And when we impact on their depressive symptoms, will actually impact, in this case, on their functional outcomes. So important to consider. So the non-psychotic aspects of treating patients with schizophrenia become very important when we think about disturbances in mood. So that's what I wanted to say about depressive symptoms before I launch into therapeutic considerations. According to my timer here, I have like 1 minute and 43 seconds. I don't see how this is going to be possible, that I'm going to cover all this, but I'll try. There's a bunch of unmet needs in schizophrenia. We know basically that schizophrenia is heterogeneous, and we know that our treatments are heterogeneous. One size does not fit all. We're going to think about what they responded to well in the past or not, what their tolerability preferences are, and so on. The FDA perspectives on looking at different aspects of the dimensions of schizophrenia vary. I'm going to go right on to newer therapies and how to frame Dr. Correll's discussion of these. We know that dopamine pharmacology is what we focused on over the past 50 years or so. And we know that dopamine D2 blockade can help with positive symptoms of schizophrenia. We also know that dopamine D2 blockade creates problems in terms of extrapyramidal side effects, hyperprolactinemia, and perhaps induction of negative symptoms by Parkinsonizing someone. We do know that serotonin 5-HT2A antagonism that are offered as a feature of our second-generation antipsychotics can be helpful and helps modulate dopamine release in such a way that we'll have sufficient dopamine where we need it, such as the nigrostriatal pathway, and have less EPS. So that's some of the theories behind why atypical antipsychotics are helpful, because of this 5-HT2A antagonism. But it's more complex than that. This is a review that was done over 10 years ago, but it's still relevant today. And it explains how, yes, D2 and 5-HT2A are important, but there are also other receptors that also have potential importance. D3 is one of them, D1 is another, and then 5-HT1A is yet another. I'd like to introduce to you some of the members of the dopamine receptor family that we haven't really paid much attention to. So D2 we're very familiar with. D3 seems to be a receptor that is involved in the regulation of cognition, mood, emotions, reward, involved in substance use. We haven't paid much attention to it because most of our antipsychotics affect D3 and D2 kind of in the same ballpark, and haven't really kind of looked at it in a special way. That may change. D1 also is important in some respects. Not too much, not too little, but just right seems to be the case. We also have some transporters that are involved in the regulation of dopamine. There's the dopamine transporter, which clears that out of the synapse back into the neuron. But we also have this thing called VMAT, vesicular monoamine transporter type 2, which is quite involved in 2 treatments for tardive dyskinesia. What this does is VMAT2 is packages dopamine into vesicles ready for transportation. When the neuron fires, dopamine is released through these vesicles. If you don't package the dopamine in the vesicle, it cannot be released. So that also is an important step in dopamine neurotransmission. And then we have an autoreceptor for D2 on that presynaptic dopamine neuron, which helps control the whole flow as well. So it's complex. It's not just about D2 blockade. And it's not just about dopamine. So we have the glutamate system, which we have some potential drugs that may affect the glutamate system and may affect dopamine downstream. Glutamate acts as an accelerant because it's an excitatory neurotransmitter. It also can act as a brake, because what if there's an interneuron in between the glutamate and dopamine neuron, right? If there's an interneuron, that's an inhibitory interneuron, glutamate turns into a brake because it stimulates an inhibitory interneuron. So very complex. NMDA is one of the receptor complexes in that for glutamate, and it's been associated with effects on sensory input and interpretation, in cognition, in learning memory, also in negative symptoms. And that's upstream of dopamine. Now, I'm showing you this slide to scare you. Am I successful? So this tells us that negative symptoms are produced in a very complex way, both cortical and subcortical. Now, this is kind of interesting because we can have relationships in circuitry between our prefrontal cortex and temporal cortex, which really will have something to do with cognition and negative symptoms. But we also have some subcortical structures, the striatum, which are quite involved in wanting and liking things. So wanting things and liking things is a theme that comes up again and again in neurobiology. And this is also involved in negative symptoms. So what I wanted to accomplish by showing you this slide is that it's not an easy ride for us in terms of thinking this through. But we can target some aspects of this with treatment. What can we do today? Well, we have a number of different second-generation antipsychotics. Some are newer. So these are the newer ones: iloperidone, acenapine, lurasidone, brexpiprazole, cariprazine. This is what they do in terms of receptor pharmacodynamics. They have different binding affinities to these different receptors. If you bind to dopamine D2 and serotonin 5-HT2A, you're in the game. And they all do that. So the squares and circles represent 5-HT2A and D2, and you'll notice that the Ki, or binding constant, is low enough so that when we use these drugs, they will work as atypical antipsychotics. When italicized, we're talking about partial agonism, but that's a fine point. But there are some other receptors here that are also important. 5-HT2A, 5-HT2C, 5-HT1A, D3, 5-HT7. They also may have potential therapeutic benefits. And they're circled or squared with equally strong Ki values. So when we use these drugs, not only do they affect D2, 5-HT2A, they'll affect other receptors as well. And that may explain the heterogeneity of response, may affect why some patients respond better than others as well, based on how their brains are wired too. Just briefly, partial agonism, not all partial agonism is the same. We have some also differences in the degree of intrinsic activity that these different drugs may have, but that's for another day. So undesirable are affinities to receptors that affect, let's say, cholinergic neurons. So anticholinergic side effects are a problem. We want to avoid them. And antihistaminergic activity is also to be avoided. We also want to avoid alpha-adrenergic antagonism. So there's some receptors we want to target and some we want to avoid. And we do kind of, sometimes we do a better job than others with some of these agents that we have available. So this is towards my last part of the presentation. We have heterogeneity in these drugs in how they affect different receptors. We have heterogeneity in terms of response in individual patients. When we look at groups of patients, they all look kind of the same in terms of efficacy. But certainly with individual patients, patient A may respond to drug B, and patient D may respond to drug F, so to speak. What's really different, though, that we can figure out that seems to be a rule is side effects. Drugs have different propensities for weight gain, somnolence, and akathisia as the big three in terms of categories for side effects. I like to think about things in terms of number needed to harm, how many patients need to be treated with one intervention versus the other before expecting one additional outcome you'd like to avoid. So the lower the number needed to harm, the more often we'll see that adverse event. So low NNH values are bad, high NNH values are good. If we have this bingo card for all the available second-generation antipsychotics that are offered first line and for the different indications of schizophrenia, bipolar mania, major depressive disorder, and bipolar depression, And if we take a look at the number needed to harm for weight gain, somnolence, and akathisia, we can see that for the most part, these numbers are rather high, which is good. Means that we will not encounter these adverse events as frequently as we worry about. However, there's a clear difference when we circle the values that are kind of low, which means not good, because the lower the number needed to harm, the more frequently we'll encounter these adverse events. Our newer ones, our newer drugs, actually perform better, and we'll expect to encounter fewer events of weight gain, somnolence, and akathisia. This is all a dynamic process when we select amongst our treatments. We have both opportunity and risk when we think about different treatments. Is it going to relieve the symptoms well enough, be tolerated well enough? Is the patient going to want to take that medicine? This involves some shared decision making, making sure the patient has adequate buy-in to the choice. And this brings us to, well, what are the choices today and in the not-so-distant future? So let me, without further ado, ask Dr. Correll to come and present.
Thank you. Well, good morning, everybody. Thanks so much, Les, for giving this erudite and wonderful talk. You're such a great speaker. I think Les is so much able to get the information across and make it very easily digestible, even very complex slides that also scared me. So we'll now go from what are negative symptoms, how are they placed within the context of the illness, how do we measure them, what medications do we have available and what mechanisms of medications might be relevant, to trying to see what has helped negative symptoms. So I'll be talking about treatment options and have separated this or divided this into antipsychotic treatments and non-antipsychotic treatments. I will be showing you a lot of meta-analyses in order to try to condense the information. And obviously, meta-analyses are only as good as the studies that they include, and I'll talk about that too. But just to anchor us, a lot of the information will be standardized mean differences, which is an attempt at pooling together effects across studies that may have used very different rating scales. But what you're doing is you're measuring the distance of the mean within a certain rating scale and divide that by the pooled standard deviation, and you get a scale-free measure, which is basically how many standard deviations are these treatments apart. And 0.2, a fifth of the standard deviation, is considered a small effect size. 0.5, a half a standard deviation, is a medium effect size. And 0.8 is a large effect size. Now, these effect sizes are placebo-corrected, meaning even though you think, wow, this is rather small or medium, what meets the eye of the clinician is also the placebo effect plus the drug effect. So when we're sometimes beaten up that our psychiatric drugs are not as effective, they are, and they're actually, as some meta-analyses have shown, not less effective than many of the medical medications that we also give a lot. They have also generally a medium effect size of 0.4 to 0.6. All right, so what about antipsychotics? You've already heard from Les that there are first and second generation drugs, and we believe that both first and second generation drugs are pretty good for positive symptoms, modulating potentially an overactive D2 system, but they are different in terms of their ability to modulate negative and cognitive symptoms, because here we do not want too much dopamine blockade. There needs to be something that offsets that, whether it's 5-HT2A antagonism, whether it's partial D2 agonism or agonism on the 5-HT1A receptor. Various drugs have achieved to not fully shut down dopamine, which hopefully is helpful for negative and cognitive symptoms. And you've also heard from Les that basically those two are very important, negative and cognitive symptoms, for functionality. Now, you have to bear in mind, though, that this is only true when you treat positive symptoms. So if we don't have positive symptoms, then negative and cognitive symptoms are not that relevant for functioning, because patients are just so crazy that in many countries they're still chained up. Yeah? So we're in the advantaged position that we're not too bad at treating positive symptoms in many patients, and then the residual or remaining components of schizophrenia that we currently have a very hard time treating, negative and cognitive symptoms, really get traction. So I will go through a meta-analysis by Paolo Fusa-Poli, but again, with all meta-analyses, you have to take that with a grain of lithium, and this in particular, because they did not necessarily take all of the data that were published in the right way. I'll show you a very recent meta-analysis by Stefan Leucht that puts the effect sizes for antipsychotics for negative symptoms into context. So these here are an overestimate of the effects of negative symptoms, because it's quite astounding why would negative symptoms improve so much with first-generation drugs that generally shut down dopamine quite a bit. And whenever you see effect sizes of, well, do I have a pointer? No, huh? We don't have a pointer. Of 2, anything that's larger than 0.9 or 1 is highly suspicious. So an effect size of 2 standard deviations better than placebo, you have to ask yourself something went wrong there. But another point is that negative symptoms come in different types, primary and secondary. And if somebody is very psychotic and withdrawn and suspicious, they will not be forthcoming. They will not mix with people on the unit. But the moment you treat positive symptoms, they might be more open to discuss things. They are less scared. So secondary improvement of negative symptoms can happen when you treat people acutely and the positive symptoms improve. Second of all, depression and negative symptoms are almost impossible to disentangle because people look flat, they're not motivated to share anything or go out and mix with other people. Third, Parkinsonian side effects really make people look like they have negative symptoms. So we need to bear these confounds in mind, and actually here EPS and neuroleptic-induced dysphoria should have somewhat reduced the effect size of negative symptoms for first-generation drugs. Now, we had about 0.5 for the first-generation drugs, and it's about 0.6 for the second-generation drugs. But these are all for mostly acute studies. So what we need to do is also disentangle this by looking at persistent negative symptoms that are prominent so that we isolate the effect and reduce something that's called pseudo-specificity by improving positive symptoms, by reducing EPS, by improving other components like depression that are looking like negative symptoms. We might then get a pseudo effect. When you look at individual antipsychotics, they look like, wow, I mean, we should see a lot in terms of our patients. Why are we even left with negative symptom concerns? So effect sizes of 0.4 for Ziprasidone, 0.9 for haloperidol again, quetiapine 0.5, although it doesn't block too much dopamine. Why is it worse than haloperidol? Olanzapine 0.9, large effect sizes. Paliperidone 0.4, Risperidone 0.4, Amisulprine 0.4, aripiprazole 1.9. Wow. I mean, have you seen, we've all had the big hope that partial agonists, especially aripiprazole when it came to market, would revolutionize our outcomes in negative symptoms. We haven't seen that, not to that degree. And the most recent meta-analysis puts everything at about 0.3 or 4. Yeah, so there were vast difficulties with this meta-analysis. I wasn't a reviewer, but people should have picked up on this. These numbers don't make sense. I'm still showing you this because there is a twist at the end of the paper, wait for it, that all of these effect sizes may not matter clinically as much. But this is the meta-analysis I was talking about by Stefan Leucht, who takes things extremely seriously and is very careful in his assessment. So this is in press with the American Journal, where he looks at 45 years of antipsychotic, or is it even 60 years of antipsychotic treatment. And it's basically that paper looks at placebo effect, that the placebo effect went enormously through the roof, about 12-point increase over 45 years, whereas a drug effect of 1.2. That's for total symptoms. So we're in trouble here that many of our treatments that we want to bring to bear now and that we study look like they have smaller effect sizes than the older treatments. But here you see that aripiprazole, for example, is in the middle, 0.3. Again, olanzapine, risperidone at 0.4, although it shuts down dopamine more. A lot of this is, again, pseudospecificity because we have an improvement in positive symptoms. But there was an attempt of two companies with two of the newer agents, excuse me, that Les mentioned, to actually say, okay, we're not interested in what happens against placebo in acutely ill patients, but what about people who have negative symptoms, and is the new treatment better than standard of care or the treatments that you would be giving? And the first trial program was with asenapine, 10 to 20 milligrams, and they took olanzapine as a comparator, and there was a 26-week acute study where there was no difference whatsoever between the two. And then when you did another 26 weeks of extension, well, there were some asterisks that emerged. But the problem here is, and I put it in the bottom, at the bottom, that basically many more patients on asenapine dropped out than olanzapine. So you have a selected subgroup. Olanzapine was better in keeping people with a number needed to treat of 6 or 7. So this is not the primary outcome. So I'm not sure what to make of that, because if you have differential dropout, then the rule of randomization, of having both groups being equal, is somewhat violated. And the differences are quite stark in terms of dropout of 25% difference or so, as you see at the bottom. So again, the trial program was then not further pursued. Now, there's another study that looked at cariprazine, the latest partial D2 agonist, that is also actually, as you may have seen on the slide, a partial D3 agonist that is D3 preferring. It's the only antipsychotic that has strongest D3 occupancy over anything else, with a factor of almost 10, a log factor. So here the question is, what does D3 do? We're not entirely sure, but it may be a relay station between dopamine and glutamate, and so there is a theory that it might help cognitive and negative symptoms. And based on that pharmacologic rationale, a study was performed and published recently in The Lancet even, so people felt this is relevant, because it showed that cariprazine beat risperidone. So it's a head-to-head study in people who have negative symptoms, trying to see, can we do better than the current standard of care? And here, as early as week 12, there was actually, oh wait, it's moving over, week 15, there was advantage of cariprazine that was sustained for all of the subsequent visits. So the question then is, does it matter? And is there pseudospecificity? Because risperidone could maybe cause EPS, could maybe not treat depression as well, a partial agonist. Cariprazine is approved for bipolar mania, but it's currently studied for also bipolar depression. So let's look at this in a little bit more detail. First of all, did the negative symptom scale assessment, which is detailed, did it actually matter in the broader picture of a clinical global impression scale? And here you see, yes, consistent effects, that it was also better cariprazine in this study than risperidone for CGI. What about positive symptoms? Are we seeing here that there's, in this study, more effect of cariprazine and there's a secondary improvement of negative symptoms? No, there isn't. Basically, both treatments were equal with a p-value of 0.96, so that there's no signal of difference, no disadvantage for the partial agonist, but also no advantage. The negative symptom score really separated nicely. The CGI improvement as the severity benefited here also cariprazine. But what's important is, does that matter functionally? And actually in this study it did. The PSP that Dr. Citrome also mentioned to you separated in all items except for the positive symptom remnant in this PSP, which is the disturbing aggressive behavior. And self-care was better, socially useful activities, and personal and social relationships, again, benefiting the partial D2, D3 agonist. But there is this other area, as you can see here, which is the pseudospecificity. I already told you, no difference in positive symptoms, but also no difference in the Calgary depression symptom scale. So there was no movement in the negative symptoms because of differences in depression. Could depression have improved? Yes, but it wasn't differential in both treatments. And also, the SAS, as the Simpson-Angus scale, there was no difference in EPS, which could have explained the finding. So it looks like there is a potential advantage here in one study against a standard of care comparator. Now, when you see a continuous outcome, you also want to see, does it matter for subgroups? And here, a categorical outcome of people who are responders is relevant. And although there is no p-value given in this table, if you look at 69 versus 58%, that's I mean, the 20% improvement is not the best threshold. I mean, we would like to see rather 40%. 20% might be at least minimally improved. So it would be interesting to know what it is if you used a higher threshold, but that was pre-specified. The difference is 11%. And that means the number needed to treat is 9. So after each 9th patient, you get one more responder in this patient population. Now, what about non-antipsychotics? Wouldn't we want to dial in other receptor systems because we think dopamine may not be the only one related to negative symptoms, as Dr. Citrome told us? What about NMDA, glutamate, and so forth? So the NMDA rationale is pretty strong because PCP, angel dust, which is a non-competitive antagonist at NMDA receptors, actually is one of the best models for schizophrenia, better than amphetamine, which just cranks out dopamine. It causes both positive and negative symptoms. So here maybe there's something in the glutamatergic system that we need to bear in mind. Then we also know from post-mortem studies that there's a decreased D-Serine in patients, and some of the agents that might increase the NMDA receptor stimulation or flow of that receptor system have been tried. So this is a meta-analysis, again, by Fusar-Poli, where he finds a small effect size, 0.3 for glutamatergic agents, pro-glutamatergic agents. And in another earlier meta-analysis, 3 different medications or molecules that can actually increase NMDA receptor transmission were tested or were meta-analyzed, and they had about a 0.5, 0.4, 0.6 effect size, which is D-Serine, Glycine, and Sarcosine. But the problem, again, with meta-analyses is that everything is mushed together, and if you look at the largest studies that were conducted, they generally don't show an effect. That's why we don't have any approval. There are small studies where you see an effect. Those are published because it must be right, but if you have a small study that's negative, well, maybe it's underpowered. So we're populating the literature with big effect size small studies, and that's potentially a problem. So we had a trial program that Roche and Genentech did with a medication that we thought, wow, we're there, we get it. Finally, we will have something for negative symptoms. We were all so excited. Bidopertin, a glycine 2 receptor reuptake inhibitor. So it would mean you're utilizing the endogenously available glycine by, like a serotonin reuptake inhibitor, you have too little transmission, so you just keep it in the synaptic cleft. You don't take up more or too much of it. And they did a phase 2b study, and that's unfortunately the fate of many medications doing smallish, medium-sized phase 2, phase 2b studies, seeing something, and then doing a big program, and then the something is diminished. So what you can see here is that in a per protocol analysis, and that should already raise your radar, so they weren't able to do ITT, intent to treat, everything is in there. No, they took the ones out that were not following the protocol, and then, okay, now we have something. And, well, did they know the dose right? That's another problem with the NMDA system and the glutamatergic system. Too little is not good enough. You don't have enough fuel. Too much might be bad because then you're over-dialing it. And glutamate can be neurotoxic. So here you saw like what's called an inverted U-shaped curve that basically the 60, the highest dose, was like placebo, and the lower doses seemed to work. Now, look at what happened here. The placebo rate was about 5 points over 8 weeks, and the drug effect was about 7 points. Then they did a huge program with about 3,000 patients. Oh, well, first of all, I show you another suggestive result here. Again, using the 20%, at least minimally improved the negative symptoms, there seemed to be something in the 10 and 30 milligram arm that stimulated this huge study. But then they did big trial programs, both for residual negative symptoms, but also for residual positive symptoms, and found nothing anymore. And now we're going from 8 to 24 weeks, and before the placebo effect was 5, the drug effect was 7, and we would expect, well, over time, the drug should really gain traction. It stayed at 7, and actually at 8 weeks, it was only 3.5 points for both placebo and drug. Go figure, unclear what happened there, but it totally blew the power calculation, and it's such an overlapping effect here. But whenever you see that something works initially, the signal doesn't fall from the sky. There must be something, and then it's totally washed out. You have to worry that you have the wrong patients in there, that maybe the measurements were not adequate. So let's talk with Bloiler. Schizophrenia needs to be talked about in the plural. Are there 10, 15, 20% of patients where this medication would work? Wouldn't we love that we can subdivide and stratify our treatment? Well, unfortunately, they have obviously looked at this in various ways. Nothing met the eye. But the other question then is, we have a lot of erudite neurobiological backgrounds. Should we take some of the measures in the NMDA or glutamatergic system where there's perturbation as an inclusion criterion? Because if we have a target engagement and we think it is glycine and it is NMDA receptor, don't we want to measure disturbance there in order to refine the signal? And I think that's where the field needs to move. Study program after study program that fails in large studies. We have most likely too much of heterogeneity in these patients. So antidepressants are most likely the non-antipsychotic treatment with most evidence. Meta-analysis after meta-analysis shows something here, the Fusa-Poli of 0.4, and then Helfer et al. From Leucht's group found about 0.3 in the total group, which is great. It also seems to help depression. So here the question is, how much do we have subthreshold depression in our patients with schizophrenia? Is it an effect via depression that improves the outcome? And when you look at the top subgroup analysis, yes, there was a significantly greater effect in people who had depressive symptoms. There was less studies in there, but it almost doubled the effect size. But also patients who had predominant negative symptoms. So here again, refining the signal by enriching the population. And that's, I think, where we need to go, where it basically doubled the effect size from 0.3 to 0.6. Brain stimulation, there are some studies not convincing at the moment, so maybe something for, again, a subtype, RTMS and the likes. What about psychological treatments? CBT. Also, there seems to be an effect of about 0.4, but we need better data in that regard too, because the problem here is always the problem with unblinding. I mean, it's so hard to blind your intervention. You could have like befriending or talking, but many of these studies use waitlist. And a waitlist is the surest way for you to win, because there is no study procedure wrapped around the patient, and the placebo effect will be minuscule because they're sitting there and think nothing is happening. Oh my God, I'm not getting better. So not even some basic assessments are taking place that are taking place in the other group. So again, here we would also need more studies, better studies, but why not pair the pharmacologic treatments we have with psychosocial treatments? That's, again, most likely what all of us would do. So do we have efficacy? What does it mean that we have standardized mean differences of 0.3, 0.5, and the like? And so that's what Fusa-Poli did in this paper that I do like about the paper, is that he actually looked at how much difference in terms of medians is there between drug and placebo and or control group. And it doesn't look that much, but then he asked another question, how much in terms of effect size would I need to have a clinical global impression changed in severity of 1? So going from extreme to severe, from severe to marked, from marked to moderate, from moderate to mild. So that's something that would meet the eye. And here it was you need about 1 standard deviation difference in negative symptoms, at least based on this meta-analysis. And when you plot all of this and you see the dotted line at the bottom, you can see that none of the treatments actually gets close. So whatever we have looks maybe great in a meta-analysis in terms of symptom reduction in free space, but if you want then to move the needle of the clinical global impression, which is a proxy obviously, it doesn't seem to cut it. Now the CGI is blunt, extremely blunt, so what we would need are analyses that take the PSP, the social and functional aspects or other scales into account to see how much traction is there in terms of movement, in terms of better psychosocial functioning. But then the other question is, both for negative and cognitive symptom studies, should they occur in empty space of just, I give a drug, I wait for the brain to respond, in patients who are in a rarefied environment, who are not stimulated, or should we have drug plus psychosocial intervention versus placebo plus psychosocial intervention? Now obviously the risk is we're overwhelming the placebo effect with the psychosocial effect. But on the other hand, if the brain is more receptive and more open and there's more juice, there's more functional capacity, would it then also get the traction and you would see people are going out more, people are maybe even able to go into a job interview and so forth. The other question that has been raised in the field is, are we barking up the wrong tree by taking always people who are about 40 years of age and have had 15, 20 years of an illness? If you want non-dopaminergic receptor systems to be dialed in, shouldn't it be in early phase patients? There are animal data to suggest once you have a lot of dopamine blockade in the system, you're altering the system and maybe the non-dopaminergic treatments are not as well suited anymore in order to show something. Now, partial agonists may be different because they do not upregulate postsynaptically, compensatorily the dopamine system. So the question is, nobody has done that to actually separately analyze non-dopaminergic augmentation in patients who are treated with pure dopamine antagonists or dopamine serotonin antagonists versus partial dopamine agonists. That would be an interesting analysis. So what we did was looking at, in a recent mega-analysis, what's the status of the field? Let's not analyze studies, let's analyze meta-analyses in order to see which kind of co-treatments might be helpful. So we looked at 42 pharmacologic co-treatment strategies in basically 4,000 publications. We evaluated 19,000 participants and looked at what would work for positive symptoms, for total symptoms, for negative symptoms, and looked at non-clozapine treatment and clozapine treatment, because these are partial non-responders, refractory patients. On that spectrum, they need something else because the antipsychotic alone is not good enough. What did we find for negative symptoms? There were actually 14 different treatments that seemed to separate from placebo by adding it to an antipsychotic, with effect sizes of 0.2 to actually over 1.4. So, I mean, we scratched our head and said, this is not what we see in clinical practice, that this seems to be so great. Actually, the only finding for where I put the dotted line is another meta-analysis we did. Britta Galling is the first author, a mentee from Germany. And in antipsychotic co-treatment, so we did a big meta-analysis of antipsychotic polypharmacy, the only finding that was significant in blinded studies was adding a partial agonist to an antagonist and negative symptoms improved. Otherwise, yes, in open studies, like the clinician says, 2 antipsychotics, wow, it works better than 1. But everybody knows, the patient, the doctor, when you take only blinded studies, that signal goes away entirely, except for negative symptoms when a partial agonist was added. But we asked ourselves, okay, this seems to be great in the meta-analyses and recommendations are being made. It doesn't make sense because we don't see this so much in clinical practice. So maybe the meta-analyses are bad. So there is a scale that's called AMSTAR, and we evaluated the meta-analyses, and because at least 10 meta-analyses were by myself and my group, they were actually of high quality. That's a relief. So the meta-analyses that are done and published now, we took the latest and largest meta-analysis, are done well. So we asked ourselves, but how is it possible then that we find for total symptoms there were 15 treatments that worked better than placebo, but nothing is approved? So we then said, okay, we need to look at how the meta-analyses are done, not only formally, but what they meta-analyze. Before I go there, for negative symptoms with clozapine, there were only 5 different treatments. It didn't seem to work. So, oh, I don't even have it in here. But what we did then was we created a scale, looked at the meat that went into the sausage, and that's where everything fell apart. Basically, the studies themselves were not of high quality, and there was large inconsistency. We looked at, you need to have the main finding replicated by the largest study in the meta-analysis. That was almost never the case. So basically, there was then a quality score of the studies, and the effect size was very nicely correlated with lower quality of the studies. So we were bound then to say, none of these meta-analyses should lead to clinical recommendations, and we need better head-to-head studies, larger head-to-head studies. Now, what I didn't go into, so some of the treatments that are interesting are SNRIs, lamotrigine, testosterone, minocycline, topiramate, modafinil, and so forth. So I show you some of the meta-analyses that are relevant in that case. So we've already seen of emerging drugs. That's a review we published 3 years ago. And 3 years later, it's already outdated. Biropertin has already lost. And Senecline, another drug that was a drug in the nicotinic alpha receptor, a nicotinic receptor system. This was an agonist, and that failed for negative symptoms as well as cognition, mostly for cognition. Now we are left with PDE10 drugs, phosphodiesterase drugs. We've heard a lot about it for some years now. It's very silent, so PDE1 is also being studied, not sure. But minocycline is something that is being studied. That's actually an antibiotic. And that's a meta-analysis we published, or it's in press now, where we looked at PANSS total scores having a large effect size of 0.6, PANSS negative even higher, almost 0.8, but it also, it didn't help for depression at the bottom. But again, the problem here is this is 156 versus 144 patients. Yeah? So this is very few patients in 5 studies, and we've seen that the small studies, early meta-analyses are positive, then a large study is done and all falls apart. So stay tuned, not ready for prime time, and might be pseudo-specificity because the positive symptoms improved. But cognition also improved. So that's a question whether there's something in the same receptor modulation area that could benefit both cognition and negative symptoms, as Dr. Citrome alluded to. Topiramate, another meta-analysis we did, showed also effect sizes of about 0.5, 0.6 for total symptoms, positive symptoms, and negative symptoms. Okay, topiramate can also reduce weight in people with schizophrenia, but we've tried it also clinically. It doesn't always help the patients with resistant symptoms to really get better. So is that another sign of having a couple of studies that show something? But I mean, since we have almost nothing available, why not try it if you've tried other things? And then you may have seen this paper that just came out by Michael Davidson, which is a novel agent. It's a 5-HT2A plus a sigma receptor antagonist. Now, sigma receptors may be novel to most of you, but they have been studied for a while. Antipsychotics seem to also antagonize sigma receptors. How much that really means anything in schizophrenia, we're not sure. Prior sigma antagonists have failed, but here we have MIN-101, Minerva 101, and it seemed in a study over 12 weeks to improve negative symptoms quite a bit, both at the lower dose, 32 and 64 milligrams. But what's somewhat suspicious is there was almost no placebo response. Well, when you put people with schizophrenia in a study and you have research coordinators dancing around them, and you give them coffee and payment, and you rate them for an hour and a half, and you familiarize yourself with them and them with you, usually people smile a little bit more and loosen up. So just a 1-point difference, 1.5, is unclear whether that could be replicated. This was done mostly in Eastern Europe and Russia, Ukraine. But another thing is, this was a monotherapy study. People were washed off their antipsychotic. So at least 3 months antipsychotic free. wow, I mean, would you want to do that to patients and then give something that they say is not really an antipsychotic, it helps negative symptoms, but maybe it could help 5-HT2A antagonism, pimavanserin, it's an inverse agonist, is used for Parkinson's psychosis, did not work for schizophrenia acutely, but maybe in stabilized patients, a sigma and 5-HT2A antagonist could keep people stable. But on placebo, you shouldn't stay stable. And here you see that on placebo for total symptoms and for positive symptoms, there was only a 1-point increase. So I think we have to stay tuned because the effect sizes were quite large. When you look here at the top, the 5-factor model, 0.4 to 0.6 effect size for negative symptoms over 12 weeks. That's quite enormous. But also negative symptom depression improved significantly, at least with a higher dose. So I think we're not entirely sure what this means. It's one study, it's not available, so that was a smaller phase 2b study. We'll have to wait for a phase 3 study. So to give us enough time for discussion, to summarize what Dr. Citrome told us, symptoms of schizophrenia go beyond hallucinations and delusions. You know it from your clinical practice every day. Negative and cognitive symptoms are common, often persistent, and impact functioning more so than positive symptoms, as long as positive symptoms are treated. Assessing persons with schizophrenia requires consideration of all symptom domains. We know that from our clinical care. Currently available treatments have mainly focused on dopamine D2 receptor antagonism, partial agonism, but differences exist, and we have some data that are encouraging. So from my talk, the take-home messages are some antipsychotics and some non-antipsychotic agents have some suggestive efficacy, but frequent lack of focus on individual agents. In these meta-analysis, everything was pooled together. Pseudospecificity, if there was an improvement, maybe in EPS, less sedation with a new drug, improvement in positive symptoms, and statistically significant differences may not translate into clear social and other benefits. So here, I think the Cariprazine study is interesting because it had no difference in positive symptoms, depression, as well as EPS from Risperidone, no difference in other aspects that could be pseudospecific, but there was a clear advantage for negative symptoms. So we did here again another study, and to also see which subgroups of patients might benefit particularly from a partial agonist on the D3 and D2 receptor profile. So we need novel treatment options, we need novel mechanisms, and we need, I think, also better animal models to translate what we find in the preclinical world then into the human. Subgroups I already talked about, and we also need to refine our trial design and conduct so that we don't have so much placebo effect. Thank you very much for your attention. Okay, let's take it from the top.
Thanks. You know, I gave Christoph the tougher questions.
Especially this one. Thank
yes.
you.
So here's one question. This is really easy. On the 2 NNH slides, what did the blank spaces indicate? Very high, very low, or not assessed? So the blank spaces are for indications not approved by the FDA for that particular indication. So schizophrenia, pretty much all the spaces are filled. Bipolar mania, pretty much most are filled. Major depressive disorder, only very few are filled, as is for bipolar depression, because there are fewer agents approved for that. So I took the data from the product labels to calculate the number needed to harm for those. So if it's not in the label, I didn't calculate the number needed to harm because there's no data to make that calculation.
Dr. Correll, does improvement in negative symptoms with a medication labeled as an antidepressant necessarily mean they are depressed? We don't know. I mean, for depression, we often ask patients, how do you feel? And patients with schizophrenia may not tell you or feel that they're depressed because they feel so barren and empty. But is that a type of depression? We really don't know. That's why we need to at least measure it and compare it.
So here, can you explain inverse agonism? Well, there's two ways to think of it. Agonism is the stimulation of a receptor. Inverse agonism is the reverse. It shuts it off. So what is the difference between inverse agonism and antagonism? Well, antagonism is when you have something sitting on the receptor and prevents an agonist from attaching itself. So this receptor is no longer available to an agonist to stimulate it. But an inverse agonist sits on that receptor, blocks it, and also turns it off. So an inverse agonist potentially, turns off a dripping faucet, so to speak, if that receptor continues to work. Even if it's an antagonist sitting on it, there's still some intrinsic signal from that system. The inverse agonist just turns it all the way off.
Okay, another question was, what about patients with schizophrenia have managed to get Ritalin or Adderall either off the street or from primary care physicians and seem to have improvement in negative symptoms but don't have ADHD? Well, yes, stimulants have been tried for both cognition and negative symptoms, but the companies have dropped it.
Well, the reason behind that is that, yeah, it probably works. However, the danger is, what if the patient stops taking their antipsychotic and remains only on the stimulant? Then you run into problems.
Yeah. So the only way to do that would be with a long-acting injectable, but again, these studies have not been done. There are two questions about polypharmacy, guidelines for polypharmacy or dual antipsychotic treatment for patients not responding to two monotherapy trials. This person is working with an ACT-team population. And the second related question, what about rational combination of antipsychotics, for example, clozapine or cariprazine or others, since the receptor profiles are known? Well, yes, we've all tried to create our own clozapine by mixing and matching pharmacologic aspects of drugs, but at least in the meta-analyses that we've done, there was no signal in blinded studies. Now, our discussion in that paper in the World Psychiatry in March is we can't discount that there is a small subgroup that might benefit from two antipsychotics, because there are discontinuation studies where people were on two were moved to one. Most people are okay with that if they're stable, but there's a subgroup that worsens. And the question here is that the subgroup that would need two? But what is rational? So we wrote a grant 4 times. I spent 3 years of my life trying to get a large antipsychotic polypharmacy study funded, having as a comparator either clozapine or a long-acting injectable. And so we were wavering. Should we give any polypharmacy clinician-driven, or do we want to have a lead-in with risperidone and then give quetiapine, a loose antagonist binding, and a partial agonist? So we went through various permutations, and the reviewers always wanted one or the other thing, and then they said, well, you're such a world-class pharmacologist, why don't you give us a rational idea what you want to combine? And we said, well, we don't know. So we did a survey with experts like Steve Stahl and Kshitish Kapoor, Don Goff, and the result of that little survey was they didn't agree on anything. So one said, I always use a first-generation drug added because it's not costly. Another said, I'm elegant. I want a partial agonist with a full antagonist, and I want a loose binding with a tight binding. And the other one was pragmatic and said, I don't mix the same side effects. I want different side effects. So we really don't know, and the data are not great. And then the last question for both of us is, you tossed this to me, does anyone yet know why clozapine is uniquely effective?
Okay, well, I'll take a stab at it. Clozapine is not really much of a D2 antagonist. So it does things in a more mysterious way. It does hit a lot of different receptors. It may also be a glycine transporter inhibitor. And that's one of the thoughts behind why it is somewhat different and may impact on negative symptoms clinically in a more profound way than the others.
So I tell you a story. 15 years or so, I went to Japan to a meeting, and John Kane was also there, and we both were invited by a pharmaceutical company and had a dinner. And then at the very end, the CEO didn't say a word. Yeah? So we had dinner, we conversed, and there was a translator. So at the very end, the CEO actually raised his voice and asked through the translator, Professor Kane, what is the secret of clozapine? And what did John say? I don't know. And so this is still the point. That's what I love about John, because he's so heads-on. We don't know. But what I don't understand is, why don't we know? I mean, we should give clozapine and olanzapine to rats and then see what's different in any downstream effect. It's most likely not the surface receptors like serotonin, dopamine, noradrenaline. I think it's much more in the second messenger system. And there lies the secret for the differences in these drugs. But we're not going there, and that's most likely a mistake, because that then leads to gene expression. But it could also be the C receptor, the clozapine receptor, that we have just not found yet. Any final questions? If not, then we hope you learned something and have a good rest of your day.
Thanks so much.